We're on week 4. We've made it this far. Good work. I have all grades in for your group projects. Most of them were really good. A big improvement from discussion 1. So I wanted to address with everybody with discussion 1. Several of you have comments in yours and you did not get grades for them. And the reason for this is I saw a ton of cutting and pasting. So what I have to say on discussion, any writing in our class is I can't accept a cut and paste off the internet. So what I need you guys to do is if you're cutting and pasting off the internet, I need you to print it out, read it through, rewrite it in your own words. One of your classmates on her group project, I'm going to share it with you guys because the kind of writing and the way she cited was very good. A couple groups got 20, but on that first discussion, I have several of you that are still out there that don't have a grade. And that's because I wanted to touch base with you. So please schedule some time with me. Some of you have already done that and I appreciate that. And if I've asked you to meet with me, it's just for some reason or another. So no worries, don't stress. We'll get through this together. Secondary, your test grades were posted as of Sunday. You guys did awesome. Really nice, several A's, bulk of B's, and few C's. So if you got a 76 or below, I need you guys to schedule a time to go over the test, but I can go over the test with anybody. So feel free to meet with me and we'll go over the questions that were difficult for you guys. Just as a happenstance, any suggestions there, any thoughts on our test, any suggestions, anything you want to say about it? Oh, dead silence, huh?
I really like the song. I wanted to tell you that I really like your review for the exam. It helped me a lot. I could have done better if I have more time to study, but it really helped me. Yeah.
Great. So the review was helpful. Good. Yes. I'm glad to hear that. What else did we find?
The only thing that made me nervous personally was the time. Like I felt like the time just went like this and it was just, the clock came up for me.
Yeah. So, and Sylvia, unfortunately we had that IT.
Oh yeah, and I had IT issues, so I started off.
Yeah, and one of our students is suggesting that it was very distracting when people were trying to get my attention. So what we're going to do for next time is we won't say, "Hey, professor," we'll just raise our hands and on that Zoom, and that way I can pull you to a private, to a breakout room, and then you ask whatever questions you need. IT was somewhat of a problem for some of us, so I don't know why, but that I know is very distracting when you're taking a test because you never want IT not to work, right? So I apologize for those that had that troubles. Luckily, we were able to get everybody tested and some of us had to join at a later time, but that was okay. All the tests are going to be a 75-minute window unless you have any special accommodations, but so 75-minute window. So when you're taking the test, what I would gauge it at is about a minute per question, because that'll get you to 50 minutes. Okay. So just if you're stuck on a question and you really can't do it, and it's been like about a minute, move on, because I don't want you guys running out of time. And that tends to be a concern there. So, but any other suggestions on study techniques that seem to work or didn't work or? No.
Oh, Professor, Yasser says that his computer, he's having technical issues.
Okay.
That is kicking him out.
Don't worry, Yasser. I see
Okay.
you. I think he's frozen, but thank you, Sylvia. So that really takes us to where we're at right now. So like I said, review discussion 1. If you do not see a grade in the grade book, there's probably a comment for you to meet with me. So we'll meet and go over things. I gave as much feedback as I could without, too much. Group projects, nice work on them. I am going to share one of your classmates. And the reason I'm doing that is she's already consented to share. But the reason I'm doing that is because her writing and the content in the questions was thorough. And for some of us, we would just answer like 1 or 2 sentences. Remember, the assignment was to reference Healthy People 2030 and their guidelines. I saw that through some of the papers, not all of them, but I didn't take off for that. It was just sort of something I wanted to bring to your guys' attention. Just be sure when you're doing these assignments, you're reading the directions because we don't always have time to go over all of them. Okay. What else can we say? You guys should be thinking in your heads on week 9. You have a vulnerable populations PowerPoint presentation you will be presenting. This is not a group project, individual. And so you're going to be picking a vulnerable population in your area. You're going to be doing what's called a windshield survey. So what that entails is getting in the car and literally looking at your windshield and seeing what vulnerable populations do you see in your area. And then once you do that, then you're gonna do some research on that. That's a heavy weighted project. So I want you guys to start planning for that. Amazingly already, we have this week and next week, and then we're on our second exam. I did do progress reports this week. So if you're missing assignments, you need to get those into me. And the reason for that is because Dr. Brown is watching, as this is a big piece of our grading. Okay, so even if you got an A in the class and you didn't complete the assignments, you may not pass the class. So that's why you got to make sure those get in. I just want a friendly reminder out there for late assignments. If you were submitting something late because you had an emergency, like I said, I would ask that you email me or text me or do both so that we're willing to be on that page. Because if they come to me late and I don't know, then I can't grade them. Does that make sense to everyone? Mm-hmm. Okay, so I'm going to show you an example of one of the discussions, and I'll try to get her name out of there, but I don't know if I'll be able to. But what I want you to look at is I want you to look at the kind of content she included in her answers. Okay, so let me pull that up. And the only reason I'm sharing this is just to show you what kind of things I look at when I'm looking at a 20 out of 20 paper. Okay, so I'm going to pull this up, and it takes me just a second. Any questions out there? No.
I kind of have one personal question.
Sure.
In my discussion, you said that I only replied to one person, but I did reply to 2 because I went back and looked.
Okay, I'll double check yours. I don't see you on there. Hold on one second. I'm just trying to pull this up and then I'll see. I'm sorry. Who was that? Who was telling me this?
Lindsay Wendell.
Lindsay. Okay, Lindsay, I'll go back and check yours. Okay.
Thank you.
Sometimes that happens. I mean, sometimes it does, sometimes it doesn't, it's all kind of, I'm looking at everybody's trying to get in there. So, okay. So I'm going to share my screen with you guys and we're going to take a look at a paper that was handed in. And the reason I'm doing this, like I said, it's just helpful sometimes to see what your classmates are doing. And you guys commented on them, so I know you guys have seen them. But here, it's asking for the nursing process for poverty. So here, what your classmate did was she described what poverty is, what our poverty levels are. She made sure to cite when she was writing. She used our book throughout here. Here, we also see a Healthy People 2030. And here, is a good one because this is what we were referencing and we were trying to look at programs and policies that are in Healthy People 2030. So she made sure to include that and look at how was our evaluation phase then. So it wasn't that she just said real quickly, this is what I would do in the end. So then we look at how would you assess the community beyond just the statistics, and she did some research to find out. How are we going to do this? We're going to look at our community resources, our leaders, our nonprofits, and see how are we going to improve our quality with our residents, with leaders, with transportation, with shelters. Also looking at our family income, size, composition, things like that when we're looking at our statistics. So here we were using that kind of research, those kind of combined studies we talked about that are really good. And she made sure to cite while she was writing. And then we look at our 3 outcomes. Now here, I will tell you, in her 3 outcomes, she really just gave me 3 different things that she was going to look at. And it doesn't have to be 7 pages to be thorough, but she was very thorough. We're going to look at healthier lives, free of chronic diseases. This comes directly out of our Healthy People 2030, because that is our goal. That's always our goal with everybody. So very good. She pulled that from there. And then economic stability and food insecurity and hunger. So, you know, this was just a paper that I wanted to show you guys to show you. And then at the bottom, here's where she included all her references, right? She made sure to include in there her different references, her Healthy People 2030, her CDC, Lancaster, which is our textbook. So she used sources that were very reliable, and they're not just like Googling poverty and things like that. Okay, so good work on that for the student that was able to share that with us. And just when you have a question about a writing assignment, when you're doing it as a group, make sure you guys are looking at each other's work, because we want to make sure that if you say, hey, that doesn't seem like enough, you can always add something, you know, and help your score come up. Scores may be different across the groups as well. If you did not do a peer response, that was half the, 5 points out of the rubric. So that was a big chunk if you didn't do your 2. Any questions on that at all? There was another group that got 20 out of 20. You guys rocked it as well.
Hi, I have a question. Like,
Sure.
my group, Nirmala and me, and one of them, Joshua, but we discussed together, and then one of the group members, she posted, and I didn't get the grade, but I didn't post the discussion.
Yeah, so for this assignment, I had asked everyone to populate so that when I'm reading them, I can know. It's so some of the groups put at the top their names. So as I was grading it, I knew who was who. So if you're a part of another group, then certainly let's meet as a group after, and we'll figure out the work there.
Okay.
Okay.
Mhm.
But like I
Thank
said, I'm human, guys. So if I didn't see something or forgot something or whatever. All right, so I'm going to take attendance real quick, and I want to mention also that Dr. Brown is watching your attestations. She has emailed the faculty several times, so please get those in by tomorrow, like around our class time. Remember, with our attestations, they are 3 questions or 2 or 3 questions, so don't just put your name in there, okay? Because then you can't get full credit. Does that make sense to everybody? All right, but overall, I'm really happy to see those group projects. They came out really nicely. You guys worked together well. And like I said, you'll be working again in week 7 for another project together as a group, and then you will rank each other and get a score on that assignment. So week 3 and week 7's assignment, your classmates will, your teammates will rate each other. So make sure you guys are all contributing and getting on the same page with that. All right, any questions on that? This week, I think we only have a case study. So this is a week where we're going to cover last week's material, and we are going to cover this week's material because I can cover it in one class. I don't usually do a recording the week of the test because I usually am able to cover the material. Okay. All right, let's take attendance real quickly, and then I will we'll move along. Natalie.
Here.
Okay, Juan. I don't see Juan. You here, Juan?
No, he's trying to log in, actually.
Okay, thank you.
You're welcome.
Normala's here. Yes, sir. I saw you. Lorelai,
Here.
Here.
Ty,
Here.
Indira, I saw you. Charity. I don't think I've seen Charity at all. Has anyone seen Charity?
No.
I'm guessing she's not with us. Heidi?
Here.
Yossi. Josie. Sorry, guys. Louise here?
Hernandez, what's the last name?
Here, Josie.
There you are. I got both of you guys. Thank you. Amoy?
Here.
Thank you. Helen?
Here.
Welcome. Raina, you're there. I see you. Katrina?
I'm here.
Jessica, I just admitted. Sylvia, I saw. Nicole. Here. Yanesi.
Here, Professor.
Thank you. Jacqueline.
I'm here.
Jocelyn.
Here.
Where's Jocelyn?
I'm right here.
I can't picture you as I'm grading your papers. That's why I wanted to see exactly what you look like. Most of you I can figure out as I can picture you guys, but at this point, but Lindsay, are you here?
Yes, ma'am, I'm here.
Yes, there you are. Welcome. And Genevieve.
I'm here.
I saw you somewhere. Okay, good. All right, so we have a full class tonight, which is good. First thing we're going to take a look at tonight was the first chapter of last week, and you guys should have caught up on the reading. This is a good week to catch up on reading if you're behind this week or last week's, because you don't have much work this week. So it's going to talk a little bit about migrant workers and rural communities. So I want you guys to take a look at a video real quickly. This is going to give you just a taste of what we are talking about when we are looking at our rural communities. Off the top, what are some things we see with rural communities?
Usually they don't have as availability to medical care as other people that aren't in rural areas.
Good.
Transportation.
Because remember, they're all
also-
spread out.
Transportation is also something else.
Tell
Sometimes
me more about that, Sylvia. What's the transportation issue?
Things such as like public transportation, even something as a car, sometimes some rural areas have less income, so they have that problem as well.
Good. Public transportation is going to be a big problem in our rural areas. Yanesi, you were saying something as well.
Yes, low education levels.
Sure. We're going to see, think about when you're in those rural communities, sometimes people don't have access to education as well as you would in an urban community, right? May not have colleges around. Your high school may be one for several thousand, several hundred miles. So just take a look at, this is a big area in healthcare right now, rural healthcare, and there's a big problem. Does anybody know what the problem is for healthcare professionals in a rural area? Nobody wants to live there. So if you're not from a rural area, the last thing you want to do is go to med school for $200,000 and then go work in a rural community where they're not going to pay. And so there's a lot of research out there. One of the universities, Indiana University, is doing a whole thing where they're helping with rural communities and physicians because they need to get those doctors out there. Okay, so we're going to take a quick look at this video, and I will tell you, it's a news article, a news story off of one of the national newses. And please just listen to the presentation, not the station, because I don't want anyone, that's all I'm gonna say. I probably shouldn't say things. Oops, hold on. Okay, we're gonna. Okay, hold on, because I want to fast forward just a little. Can you guys hear it?
There's no volume.
Okay, hold on. I have to share with you guys. Okay. So remember, we're talking about our rural communities here.
We can hear, Professor. It's not volume.
Yeah, no volume.
You still can't hear?
No, we can see the screen, but no volume.
Hold on, let me do it again.
is Park
about now?
County, Colorado. About a 90-minute drive from Denver with a population of 16,000 has not had a physician for the past 2.5 years. The community-funded $600,000 state-of-the-art medical facility they have has sat empty in that time, even with the offer of the bargain lease price of $1 a year. The National Rural Healthcare Association says Park County is not rare, and it is seeing declining life expectancies in small towns. Regions of the country that have a higher percentage of people age 65 or older and are more likely to be a long drive from medical care. In Park County, folks end up driving up to 2 hours for a doc. It's a hindrance for folks like Army veteran Jerry Ferris and his wife.
He could get his care right here in our town if we had a place for him to get it, instead of driving 60 miles one way when he has severe neuropathy in his feet. I can't drive this week. Had surgery.
Things are so bad in Park County, Shannon, that they have 2 ambulances in town that are overwhelmed because they're constantly called for things that are non-emergencies, things you'd see a doctor for, like a sprained ankle, things like that.
All right, so how do we get to this point, Alicia, and what can be done to resolve it?
Yeah. Well, the fact of the matter is small towns are simply not attractive to medical students who are just graduating and heading out to be doctors. And that makes it really hard, especially when you consider that the average med school debt upon graduation is close to $190,000, according to the Association of American Medical Colleges. The NRHA says the whole way in which med school is approached needs to change. And they want it to change, Shannon, in the way that they say what they need to do is recruit people from these rural areas and get them trained so that they can then place them back in towns that they're used to, a lifestyle that they're used to, and honestly, around people with an income that they are comfortable with. Shannon?
All right, Alicia Acuna, thank you so much.
Okay, we're going to stop there. So that was just a little brief, a brief scenario of one rural place that happens to be local to me, but that's not why I showed it to you guys. But I wanted to know about your areas where you guys are. What kind of rural areas do you see where you are?
I live in Tennessee, so there's a lot of country out here. I don't know like the statistics or anything like that, but there are a lot of places that, like, especially like when it snows, they're totally, and it snows like just a little bit, they cannot get out, they can't go anywhere. So like there's a lot of rural places out here.
And how far is the most of the local hospital for you?
For me personally, not far at all, like 10 minutes, couple of miles.
And is it
not
a
far.
community hospital or it's like a big level, trauma?
No, the one that's in my town is just a small hospital, but like Vanderbilt is in Nashville, which is huge, and that's maybe 20 minutes away, 25
Okay.
maybe, not far.
Yeah. Which is good. So where you are is not particularly rural then,
Yeah.
right? How
But
about
like
those?
my dad lives where my dad lives, there's nothing out there. I mean, they literally probably have like a couple of maybe 2 gas stations, 1 grocery store, like stuff like that.
Yeah.
So he has to go to the next big city, which is Chattanooga, in order to get anything.
Okay, and that's pretty far for him.
Yeah.
All right, there was another interesting report on rural health, and one example was a guy who was having a heart attack. So what he said was his wife drove him an hour, because if he called 911, by the time 911 came, his reporting was that he wouldn't get to the hospital for at least an hour and a half, because by the time they get there and pick him up and take him back. So meanwhile, the guy's having a heart attack in the car with his wife. Wife doesn't know what to do, as most people wouldn't, right? So he was very fortunate, but his care was compromised because of the distance he was to all these facilities. So things to think about with our rural population. They are going to be really vulnerable to stuff. What other things you think is going to be vulnerable in our rural populations? What kind of disease processes are
Pregnant
we
women?
missing? Pregnant women's a big issue.
Probably diabetes.
Good, go a little broader.
Respiratory disease.
Keep going.
Heart conditions?
Keep going. You guys
Yes.
are all saying something that's it's under a big umbrella.
Chronic
Spencer?
diseases.
Or chronic diseases, yep. Why do you think we're gonna see this rise in chronic conditions in our rural areas?
Because they don't have the resources to either prevent by education or to be able to adequately control the disease process.
Yeah, and remember, they're not gonna be having their well checkups, right? Like people who are in an urban community.
Yeah, and transportation issues. Yeah.
Yep, we spoke about the transportation one, and thank you, because I remember that public transportation is not there. So if you don't have a driver's license or you don't have money for gas, the last place you're going is the doctor's office, right? Unless it's an emergency. Things to think about when we're looking at this community, and it's really an area of complete need. I know that I've had other students from Utah. I think I have one in here, don't I? Anyway, yeah, that's right. Jacqueline's from Utah. And there you have huge areas. Jacqueline, just give us a little scenario where you are. Are you in a more urban area?
I'm in this suburb of Salt Lake City. So I am like in the heart of the county. I know that like to the west of us, the further west you go, I mean, it's starting to develop, but it hasn't always been that way. So the further west you go, the more rural it is. And so, but then again, if you go south or north, you know, you will find more rural areas that there isn't a lot there. And I grew up in Missouri. And so like I had 3.5 acres that I lived on growing up. And so the nearest, like our town, I kind of laugh about it now. Like we were so excited when we got our first actual street light put in, because our town only had 3 of the blinking ones that, you know, you treated as a 4-way stop. And the nearest hospital was like 15-20 minutes away.
Yeah.
So, you know, it's interesting that now it's like within a stone's reach. I've got 3 hospitals that literally it's 6s either way I go. It just depends on what kind of care I want to receive.
Right, and thank you for bringing that up, because that brings up something else. A lot of, and when I asked Lindsay about community hospitals, we know that the quality of care, meaning the intensity of care that is going to be able to be given in these small places, is not the ones that we're going to find like in Boston, where we have 7 hospitals within a, you know, walking distance, or Philadelphia, where we have some of the best hospitals in the world, you know. And so the kind of care they're getting, sometimes they don't know any better. That's all they've ever known. They don't know to go somewhere bigger and better. Not always bigger and better is better, but at least they'll have more opportunity, more surgeons that can do things, more physicians that are working, more nurses that know things like that. So keep that in mind when we're looking at our rural. I really want to focus too on who's going to be, what's our population going to look like in our rural communities?
It's going to be a lot of elderly, possibly, and then they're going to have a reduced access to medications. They may only have like one pharmacy that they can go to, and everything has to be special ordered.
Mm-hmm. Yeah, and think about when we're in these rural communities, what do we have a lot of? What's there a lot on the land?
Pesticide.
You're there. Where do we spray the pesticides, Tia?
On the crops like the corn, and on the food and stuff like that.
Yeah, on the farms. And who's working on the farms?
Farmers.
Sometimes.
Yeah.
They usually want some
immigrant
help.
workers.
Immigrants.
Migrant workers
right?
that might not have insurance.
Yep. So you're going to have that combination. What happens when you have people from another country that are working in the fields? Maybe the English is not the first language. They can't see a doctor within 50 miles. What kind of care you think they're going to be getting?
No care at all. Or, yeah.
Yeah, none.
Yeah.
You're not going to get care. I mean, they don't have the ability or the knowledge or the resources, like, you know, and English second language for all of the world that we have and all the people in America. Keep that in mind, guys, because that's a real hinder for them. So I'm going to just look at, I added a couple PowerPoints to the book PowerPoint because I didn't want to forget anything. So I'm just going to pull up PowerPoint that I sent you guys from the book, and we're just going to look real quick. We did all this stuff. So When we look at our rural communities versus urban, we're gonna have those farms where we talked about. We're gonna have those immigrants, okay? As opposed to our metropolitan areas or reasons that we go. We have our migrant workers. Let me do this as a slideshow because it's too small otherwise. We have our migrant workers, right? What are some health concerns we're gonna have? What are some primary preventions we're gonna do with our migrant workers?
Hygiene.
What are we gonna do about hygiene?
Nutrition.
All right, you guys are hitting things that yes, but what are you gonna do as a nurse in a rural community with these guys? What are you gonna do to, it's a primary prevention?
Vaccination.
Vaccination.
Good, vaccinations for sure. Remember, they're being exposed to pesticides. What are we gonna make sure we do?
I would think
Masks and gloves.
I have a couple answers coming in, so if you want to put it in the chat, or that's probably best, but I'll take a look at everyone. Mask, PPE, good.
right, respiratory and stuff like that because of their breathing in all those pesticides.
Right, but remember, what are we gonna do before they're breathing in the pesticides?
Educate them on the outcomes of if they don't use the PPE stuff.
Yep, you're gonna educate them. We're gonna do this before they start, if we can catch them before they're working, right? Which is pretty difficult to do, but we're gonna try to educate the farmers, right? Because they know then their workers are gonna be susceptible to this, and these are some things. We talked about communication. A lot of times they're coming from another country, so maybe not. What kind of screenings are we gonna do in this group?
Pesticide exposure.
Yeah, pesticide, what else?
Cancer, maybe.
Tuberculosis.
Yeah, maybe some cancer. What else do you think about? Look at this guy. He's carrying this heavy box. What kind of screening are we gonna do?
Respiratory?
Certainly respiratory, because they're compromised, that's for sure.
Back.
Teach them
What'd you
how
say?
to lift and carry things without straining.
Good. Sylvia and Jesse, thank you. Both of you are right. His back. These people are gonna have their muscular system strained beyond belief. We're gonna see sciatic nerve possibly. We're gonna see all these things, right? So we want to screen for these. Are you having pain when you do this? Are you doing that, right? Those kind of things. And then when we do our management, we're gonna treat them for pesticide exposure, right? And we see an increase in chronic diseases in that community. We know that. Okay, here we go. And then we look at our different immigrant groups. We're gonna have different types of treatment. What do we have to be careful with when we're treating our immigrant population?
The culture.
Treatment.
Culture, what do we have to be really sensitive to as nurses?
We have
Starts with
to
a B.
respect their beliefs. Yeah, their beliefs.
Their beliefs, but not just their beliefs, whose beliefs?
We need to shake our own beliefs off so we can treat them adequately enough without biasness.
Right, we got to be really sensitive and aware of what we think and what we believe, because a facial expression to some cultures will tell them right away you're not trustworthy, right? So you got to be really careful with that, guys. So think about like faith healers, whether you believe, you don't believe, they believe. So you have to immerse yourself in that, get knowledgeable in it, know about it. Communication is always going to be our big barriers. Know that in our rural communities, we're going to have a decrease in leisure activities, okay? So we're going to have working around the clock. These are farmers, they're taking care of livestock, they're up at 5 a.m., they're working all the time. There's a sense of familiarity, meaning everybody knows everything. If you know the farmer, you know the workers, you know this guy, you know who he's married to, you know his kids, you know what his kids do, things like that. Resources, travel distance, we talked about, things are far away. So characteristics that we tend to see in our rural communities that we want to be sensitive to: higher proportion of whites, higher than average young and old. And why do you think that is, that we have higher young and old? We're on the spectrum here. We have less in the middle.
as soon as they're old enough, they move to the city. I guess the older teenagers.
Sure. Some of them say, I want to get out of this. I want to be, in a city. More likely to be married or widowed, fewer years of formal education. They're usually poorer and they have a higher risk of being uninsured or underinsured. Okay. We know how expensive the cost of insurance is. So our barriers we look at, like we spoke of, I'm repeating myself again, but our poverty rates, our education, our transportation, our unemployment, sometimes there is nowhere to work. They don't own a farm and there's only one grocery store in the area. You're not going to have Walmarts and Walgreens and everything else where you could get a job. You're certainly not doing DoorDash or Pizza Hut, right? Because you don't have that available there. So think about that when we're thinking about this population. We also see a lack of access to healthy foods and physical activity. You're rare to find a gym in the middle of, Kansas. Not that there aren't ones here and there, but you're not going to have one in the middle of a farm area where everybody has, 10 or 20 acres. Some that we see. We know that our healthcare providers is a problem. We know there's a shortage. We talked about why that was. We see a higher infant and maternal morbidity rate, and someone spoke of that. Why do you think that is?
Because they have no access
You're
to
gonna do the right
healthcare.
prenatal care.
Yeah, prenatal care is really hard, right? There was a patient who lived in the middle of nowhere pretty much, and she was pregnant with her third child, and she had a clotting disorder. Well, she goes to the local GYN and they're like, no, thanks. They know the liability there. So you're going to have a hard time having high risk pregnancies in these areas. Sometimes they don't even know they're high risk. Sometimes they do. So think about our variations. And we do see it, unfortunately, victims of sexual assault in these communities that is not being shared because they try to keep everything pretty quiet. We know that our urban children are going to be more likely to see a pediatrician. Our mental health is high here. And this is another area that we read about last week. And I'm not going to go over this again. So one thing to think about is our migrant lifestyles, our housing. Our Migrant Health Care Act came in 1962 to help out with migrant health, but this is still a problem today. We are not up on it as far as knowing the limitations we have with finances and healthcare. This is really an area that is hurting tremendously. Things to remember is our client relationships and, like we talked about, our biases. And on our Healthy People 2030, we're going to see that we're going to try to have our communities involved, consider how to use the resources that we have. We're going to use technology. This is where we're going to see a ton of telehealth. Has anyone done telehealth? And this is a great resource for them. So I've spent many years doing telehealth. And what did you find with telehealth? I think Heidi shook her head. What did you find doing telehealth?
I think it's easy access. Like I really had an emergency, and I called them and they said after they did everything, just go to the emergency room, and I spent 3 days over there. So it was easy access and they actually treat me super fast. So
Good.
that was good.
Good.
Yeah,
And they told you it's emergent. Go ahead, Nicole, sorry.
I'm sorry. Yeah, it's also easier, I think, for like the elderly that maybe like if they have to come in, if they're not feeling well, or if it's maybe for like results. We do that in our office. It's harder for the transportation. So they do a lot of telehealth for that. I think it's easier for the elderly.
Good. And when you do your telehealth in the office, do you ever come across where you call a patient and you're talking about their health, and by the end of the conversation, every grandchild they have and what they do for a living?
Yeah,
and if the cleaning lady came that week, or if they're cleaning, or if they're mopping the floors, or right, and what kind of couch they have, and all those kind of things, right? So telehealth is a great area for working with our mental health concerns, because people on the phone are tend to be more likely to disclose information. Okay, so that's our PowerPoint on our migrant and cultural concerns. Any questions on that? Because that will be a chunk on our next exam, as usual. But what we're gonna do for the next section is we're gonna do a Kahoot together. And what that'll do is that'll review our material from last week. And it lets you guys participate. I'm really hoping that somebody, maybe just one of us, read the chapters so we kind of know some of it. But if you don't, this is a time for us to go over it, okay? And it'll be helpful. All right, so everybody ready for the Kahoot? Okay, here we go. I will share it with you in just 1 second. And I find Kahoot's helpful to review content just in case you didn't get a chance to read. I mean, guys, I know the book is really boring. And the print is so tiny. That's what I think. They need to make the print bigger. But so I know it's hard to keep up with all the reading, but I want you guys to use this week, like I said, to catch up on reading if you're behind on the reading. Because I don't know if you guys sensed, but in our test, there was content that was covered in the class, but it's broader. You know, I can't cover I can't teach to a test because you guys need to take your HESI and you guys need to pass that. And so what we create on the test is we do that in cahoots with our HESI. We know what's on the HESI, but you know, everything, there's so much to learn in any chapter that sometimes it just seems like there's just so much. Okay, here we go.
So before you start, the PowerPoints that you shared are from the first couple weeks up to today? Or?
No, just from last week, the first chapter of last week.
Oh, okay. But that was from the previous test that we already took.
No, that's going forward. Because because our content was from last week after the test, but
gotcha. Okay.
Yes, there might have been a little touch of it, but not much. Okay, we're gonna do our Kahoot. Okay, and your pin is coming in just a minute. Okay, here we go. All right, our pin is 283-3524. Halloween's Monday, right? Not Tuesday, right? Yeah, okay. I just want to make sure that we weren't going to be, I mean, for those of us that have trick-or-treaters or whatever.
Professor, one thing, some of us have pediatric class after this and we have an exam. So I don't know if we can get like 15 minutes before the final of this class.
Sure. Will you remind me, Nirmala, towards the end?
Sure, will do. Thank you.
Yeah, I'll cut it 15 minutes for you guys, okay? All right, here we go. First question. Going to be about our immigrant population. All right, we're working with Mexican immigrants. What behavior would most likely lead to a positive interaction when we're dealing with our Mexican immigrants? Avoid touching the client except when necessary. Call the client by name, socialize, and be respectful. Keep all clients direct and targeted on their research, and maintain a non-confrontational relationship. Avoiding any disagreements. Oh. All right, you guys were good. All right, most of you got this one, good. And so what we want to know about our Mexican immigrants is that they are going to want you to look at them. They're going to want you to call them by name. They're going to want you to be personable with them and, you know, really engage them in it. You know, maintaining non-confrontational always, but with our Mexican immigrants, we're going to see a lot of that social contact, that physical sometimes, you know, is a good thing for them. So something important to remember when we're looking at that group. All right, the next one. This one is pretty direct, so I'm going to skip it. RN, tertiary prevention strategy for pesticide exposure. What are we going to do? Tertiary, treat a client who has pesticide exposure, teach farm workers how to recognize signs, observe farm workers, or provide teaching on how to handle. Ooh, yes, most of us got it. Somebody who picked red. Why did you pick red?
Because they're already exposed, and so you want to teach them how to treat it to avoid further exacerbation of the problem.
What do we know about tertiary prevention?
Treating the patient.
It's
Go ahead,
treatment.
Yanesi. What'd you say?
To treat and minimize what they already have.
Yeah, the T and the T go together, remember? Tertiary and treat. So that would be our only choice. What would green be? Provide teaching.
That'd be
That's
primary.
before primary.
Good. Yep, our primary is going to be our teaching beforehand. Good work. All right, who's going to have our highest incidence of poverty? 18 to 64, 18 to 25, under the age of 18 or over the age of 65. Oh, everybody thought the older population. One person picked 18, and that is because we are seeing a large evidence of increase in poverty among families. So those under the age of 18, we're going to see that as a real problem for them. Those older people can, but they're not going to be our highest rate. Our highest rate that we're going to be seeing now is families coming into poverty. All right, most rapidly growing group of homeless. Very sad to think that families with children, persons in crisis, single men, or adolescents. Very good. I just sort of covered that, guys. Our families are our biggest group that are encountering poverty and homelessness currently. So the answer person in crisis, I see 4 of you picked that. That's a kind of general term that we don't know what the definition of crisis is, right? We know what a family in crisis is because that was on our last test, and that was when they can't handle things. They say, I just can't deal. But we don't know when we're looking at persons in crisis, because crisis could be subjective. Okay, so good. We're going to see our families with our children. Now, this is covering one of the chapters from last week on vulnerable populations, right? Does everybody recognize it? Well, don't answer that because maybe didn't we, but okay. Pregnant women, single pregnant woman. This is another group that we're seeing become a vulnerable population, and that is because of elevated BP, first prenatal visit, homelessness, or positive STD. Remember, it's most concern, most concern. I had a feeling this would be across the board. Okay, so 5 of us picked homelessness, which is true. Why is homelessness going to be our biggest concern?
Due to
Because they're
financial
very-
support, they're alone.
The mom not gonna have anything to nourish the baby. Like if she's homeless, she can't afford food, so the baby not being well taken care of.
What else do we know about homeless, Heidi?
Also, you know, the safety, they're at risk because they're on the streets. So, and physically they cannot take a shower, you know, they still, you know, the confidence is really bad.
Right. Well, everyone, I think, would agree that all of those are concerns if we're doing maternal health, right? We're worried about all of those. One elevated blood pressure is not going to send us to the hospital, right? We do know this. Yeah. You got to have a trend. You got to see it. You're going to do labs, things like that. That's not going to be of most concern initially. First prenatal visit at 5 months gestation, at least they're getting care. That's how I would interpret that. And a positive STD, we treat it. You know, but that's not going to be our utmost concern. Our homelessness, we're not going to see them. They're not going to come for any prenatal care. you know, they're not gonna know where to go. They'll come when the babies do, or when they have contractions, or when the baby's falling out, right? So this is gonna be our biggest concern. And that is with our vulnerable population. This is another one with our teenage moms and a month-old infant. What do we need to make sure she knows? Assess mother's ability to fulfill her own growth and development. Assess for knowledge about normal infant growth and development. Assess how much the teenage mom's own mother is helping, and assess whether the baby's father is being helpful. It's going to be our priority. Good, 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 good. Most of us got this one. Why is this one important? Why are we making sure they know normal infant growth and development?
Because
if you know normal, you
is not developed.
Lorelai, did you say something?
Yeah, they need to know when to seek help or when something is wrong.
Exactly. If you don't know norm, you don't know abnorm, right? Very good. So that's going to be our biggest concern. Mom's ability, we're hoping that she can take care of herself, although that is a concern if she can, because then she's certainly not going to help with take care of a mom. All right, we are going to look at now leading cause of disability for 15 to 44-year-olds. What do we think it is? Accidents, depression, arthritis, or workplace? Oh, we were split there. Accidents are going to be most common for what age group?
Adolescents.
Adolescents.
And the little ones, the little people, right? Children. Because they have accidents all the time. They fall off the bike, they fall off the gym equipment, they do a handstand and don't know how, right? Broken wrists, broken feet. We're going to see major depression. We're going to see depression across a lot of these different age categories. So I want you to keep that in mind. We're gonna see that as a concern here. Arthritis, nobody picked. Workplace injuries, interesting. Well, that would only, no, it's an okay answer. Not your best, but that's an okay answer.
Here in Florida, it is.
All right, which of the following groups is most at risk for suicide? This is not what you would think. Yeah, see, I told you, it's not what you would think. We're going to see highest risk out of this group. We're going to see suicide as being very high with adolescents under the age of 20 and extremely high with our older people because they don't want to be here anymore. So something to think about with our mental health. Remember, we talk about elder abuse as a concern, things like that. So I would have taken, if I were writing this question, I would have taken red or yellow because our adolescents we know are at risk, but I didn't write the Kahoot, but so I would take red or yellow on that one, but our older people are going to be high risk as well. All right. Trying to decrease the risk for depression among our older adults. What should we do? We're going to encourage moving to a nursing home, organize healthy activities at the senior center, monitor for signs and symptoms, or teach clients to focus on their strengths. Now, best intervention here. Excellent. All right. What is the benefit of organizing healthy activities at a senior center?
Because you actually, keep them out of the home, you make them socialize with another group of people their age, so they kind of like have activities and they feel better.
I want you guys to, go ahead, Juan.
No, I was gonna say also just physical activity, they're moving around, blood flowing,
What are some things that will make a person depressed if they have a tendency?
Sitting with their thoughts.
Feeling of isolation.
Isolation.
Yeah.
Loneliness, right? They feel like they've got nobody. That's going to make their depression even greater, regardless of the age. You want to get them around people and people their own age that they can, you know, have relationships with. Good. All right. And then we will have, we move into drugs, alcohol, and tobacco was the last chapter of last week. So what is our best way to approach addiction? Criminal justice system, harm reduction, punishment, or substance abuse education? Remember, we're approaching drug addiction, so we have to be careful how we answer this one. Oh my goodness, everybody picked education. What's your thought there? Anybody, you can put it in the chat if you don't want to say.
If you teach for example, the teenager, the consequence, the healthy issue that you're gonna get if you use, I don't know, drugs, alcohol. That's
Okay,
why
there's a
it's
keyword.
education.
Okay, there's a keyword in this question that I want you guys to look at. What do you think that keyword is?
Most effectively.
Education.
There's no education in there, but there's another word that has the shun on the end.
Approach.
Oh, approach.
So the patient is already addicted.
So the
Yeah.
last word in this is addiction. We're not saying drug use, right? We're saying drug addiction. So once they're addicted, you can educate them all you want. That is not going to help us, right? To work with our clients who have our drug addictions already. Does that make sense to everybody? You can educate all you want, but it's kind of late in the game. You know what I mean? So on these ones, we're going to be doing harm reduction. So we're going to say, who are you around? Where do you find this? Why do you partake? You know, those kind of things. So we're going to try to reduce all those places or people or circumstances to reduce our addiction. Okay. Which of the following is both legally and culturally accepted throughout almost all the world? Beer, cigarettes, caffeine, or mixed alcoholic beverages? It's legal, remember? Across the board. Oh, all right, we got most of, we were split on the alcohol and cigarettes and the beer. So what do we know about caffeine?
It's addictive.
What else is it?
It's a stimulant.
It's a stimulant. What else do we know about caffeine? Do you have to be 18 or 21 to buy it?
Nope, any age.
Nope. There is no restriction there.
access.
Yep, easy access. And our young kids are, I have a freshman in high school who in the morning, she says she needs her coffee. I mean, I say, okay, I think she likes the creamer more than the coffee, but you know, I say, fine, you know, but you have to be careful with that because young kids are taking all kinds of drinks with caffeine in them. What are some other ones we see other than coffee?
Energy drinks.
Yeah.
What's that do to the cardiac system?
Speeds it up.
Hypertensive.
Tachycardia.
Yeah.
Accelerates.
Yeah, and all those things, we do not want that being done to young children, right? It's not a good thing. So think about that. And culturally accepted, there's not many cultures that I know of. If you guys know of one that won't drink coffee or tea, I'd be interested, but I don't know many cultures that are saying, no, you can't have coffee or tea.
Actually, the Mormon culture,
Yeah, they take no stimulants. You're right. That's
yeah,
true.
they discourage teas and coffees and alcohol.
For the stimulant. Yeah, they don't drink alcohol. That's a definite, but yeah, thank you. I forgot about that, Jacqueline. All right, and then what's our big concern with marijuana is now legal in many places over the age of 21. Has painful withdrawal, can reduce pain, but physicians refuse to prescribe it, may damage the respiratory tract, lead to psychological dependence. Alrighty. All right. Why is marijuana with the respiratory tract? Why is that our biggest concern?
It's still smoke that's going into your lungs.
Now, I don't know if anyone knows, but I learned a couple weeks ago, I'm probably just novel to the idea, but now what kids are doing is they're getting these wax things. They look like lip gloss, like the old fashioned lip gloss, like little circles like this. And it's wax. And so they take the wax and then they light the wax with a butane lighter and inhale that. The high they get off of that is so high that you almost need to give them Narcan. They're almost non-responsive. Palpable pulse, usually not present. Blood pressure, usually can't get it. It's the dose of the actual drug that they're getting in their system is so high. And so just be really careful, guys, because they're vaping, they're smoking it. It does not necessarily smell like the traditional marijuana used to smell. Okay, we have it all different forms. Think about that. Is it legal in Florida?
Medically.
Medically. So in the state of Colorado, it is legal. So we have pot shops is what they're called. And they're all over the place and they look like 7-Eleven and they just have a little marijuana picture. Well, they sell in there brownies, gummies, cakes, drinks, all kinds of leaves. I mean, they sell everything. So think about all the things that we may be seeing and maybe we're not familiar with all of them. So keep yourselves up and about with the use of alcohol. I mean, sorry, the use of marijuana and all that's coming out, because what's happening is kids want that automatic high and that wax is the latest and greatest now. You know, it's a little scary. They're using a butane lighter that should be included then. Probably not a great idea, but you know, if that's what they're using it. What a lot of people are going to be using marijuana or any of the drugs or alcohols for what kind of treatment? What are they treating?
Pain.
Cancer pain?
Pain, cancer.
Attention deficit disorder.
Also,
MS,
people who
MS.
MS, good. Migraines?
chemotherapy.
Migraines?
Chemotherapy.
Chemotherapy. They're also sometimes treating their mental health, right? Keep that in mind.
Yes, that's true. Yeah.
Anxiety, chronic back pain, you see a lot of that, medically prescribed or not. Because you know they were addicted to the opioids and then they got a card and now they can buy the marijuana. So now they're using that in the same system. So just think about that with our addictions. All right, I'm going to stop there because I want to give you guys time. And so that covers our chapters from last week. And I'm going to cover this week's chapters in the next section. But any questions on what we covered so far? All right, I'm letting you guys out 15 minutes early so you can study for peds or whatever. So let's take a 5-minute break, okay? It'll be 5:06 my time, which is 7:06 your time, okay? So I'll see you guys back in a few minutes. Sorry, guys, I'm a minute late. That was a quick break. All right, so we are going to look at 3 different things for the rest of tonight. And the first one, I'm gonna have you watch a video on because I want your opinion on it. So hold on one sec. All right, here we go. What? It doesn't want me to play it. Okay. I know, hold on. Sorry, I just want to get it. Alrighty. Share our screen here. All right, here we go, guys.
When she discovered she had both a hole in her heart and breast cancer. Unemployed and uninsured, James Dobson's high blood pressure was life-threatening. Shortly after Karen Houston's husband suffered a nearly fatal brain aneurysm, her daughter was diagnosed with diabetes. Unable to sustain her oxygen levels, Lily Giacchetti spent more than 1 month in the hospital. Though these people were dealing with devastating illnesses, they did share one advantage. They each turned to their parish nurse for support. Across the country, parish nurses practicing the specialty of faith community nursing are improving public health by reclaiming the historic roots of health and healing.
This is your bubbler. How often do you change the water?
I have to change it every day.
When Mrs. Lily Giacchetti was hospitalized for nearly a month, parish nurse Ramona Davis made daily visits.
My illness was really serious, and everybody knew it.
I visited with her. I followed up and explained a lot of tests that she was required to get that she really didn't understand. When she was ready to be discharged, I made sure she had her equipment, she had visiting nursing, she had her oxygen set up.
128/70. That is really good. You are doing such a wonderful job.
Yeah, that's right. There are a lot of churches in our neighborhood, but there's only one parish nurse. And people will come in, they'll leave other churches and stop by to see Ramona.
I wonder how in the world I could have done ministry without a parish nurse.
So I'm going to give everybody a handout.
Ramona's duties range from assisting the critically ill to supporting church activities and promoting wellness.
I do a lot of health teaching with the kids from the school and the confirmation kids at the church. So we're going to look at it from a religious standpoint. We currently have a gospel aerobics class, which is intergenerational. we get to interact with people on an everyday basis. If there's a change, you notice it.
How was your blood pressure the other day?
It
Okay.
was 135 over to 85.
Oh, goodness.
We have these long relationships with people.
Okay, take a deep breath.
I've known some of the people that I care for now a good part of my life because this church is where I was raised.
These long relationships enable parish nurses to treat the body, mind, and spirit. When Karen Clohesi's world was
All right, we're gonna stop right there. All right, any thoughts on that video? What you guys saw? No?
I thought it was interesting that they had, and like, they called it a parish nurse, that everybody came to be, you know, looked at, and she took on the role of, I mean, really the community nurse of educating and implementing aerobics and, you know, things like that. I thought that was a really cool thing.
How many of you have heard of parish nursing prior to this video?
Never heard of it.
Never.
Read and I never heard of it.
Okay, good. That was my point to you guys, kind of, is that this is not an area that we often hear about, but what it is it's a nurse who takes on, doesn't have to be part of the community. In this video, they were, but they don't have to be part of the church. What they will do is they will work with physical, mental, and spiritual well-being of people. Okay, so in many churches, they will have a member that's a nurse that can be a parish nurse, but sometimes they'll just have somebody in the community that wants to be a part of helping out in a parish community. Some things we want to think about with parish nursing is what kind of things are we going to be considering if this is an area that we go into?
What's available to the community? What types of resources, what types of education, what, you know, medical, I mean, that's a huge thing is knowing what's available easily to the people that you're going to be taking care of or helping.
Okay, so our community resources, what else do we need to know? If you're going to work with a community, what kind of things do we need to know about the community?
The
Culture?
chronic conditions
The current conditions
that are more like prevalent, like chronic conditions that, you know, it's more like in that community.
Yeah.
Yeah. And what other things are going to be really important? It's going to be hard in a church unless the church is all has the same genetic background. It's going to be hard to have something like that. You're going to have a wide range of things. But what do we really need to be sensitive to when we're working with a community and faith?
The culture and their beliefs.
Religion.
Yeah, right. Religion, their
And the-
beliefs.
Yeah, and depending on those factors, you know, some of them like certain vaccinations, medications, the release on those things.
Right. Think about Jehovah's Witness community. What do they not receive?
Blood.
Blood
Blood.
Right. So if you were a parish nurse working with that community and they say to you, I'm not going to take blood, what's something you could say back to them? It'll be therapeutic. I don't know if you guys have
I guess as a prevention, you can tell them that you can draw their blood prior to anything, you know, and they could use their own blood later on, I guess, maybe.
Right, and it's not something with the mother cells.
Say what, Helen?
It's not something with the mother cells. I don't remember the name, but I think it's. the
It's
mother
called Cell
cells.
Saver. I think that's what you're talking
Yeah.
about. So it's
Yes.
actually it's artificial. Cell Saver is artificial, but it's not blood product. So it'll save the cells. Good. Respect their decision, Tia, for sure. And what if we believe that that's a bad decision?
We have to respect it.
We have to be unbiased. We have to respect.
Yeah, Jesse, what were you gonna say?
It doesn't matter what we believe.
Yeah, pretty much.
Yeah,
Doesn't
respect
believe.
and then document.
Yeah. And think about if you're working in a Catholic church, or you're Jewish. What are some things, well, you don't have to share if you're Jewish or not, but any Jewish traditions you know that may be different than a Catholic tradition?
What they eat.
Their nutrition, yeah.
Could be nutrition, sure.
Their holiday schedule.
Yeah, holiday schedule. What else? How about end of life care? Does anybody know the difference?
I know that for the Jewish community, they more live at the moment of what's going on right now, and as to going further, they usually don't think of like hospice or anything like that because it's more like what's going on right now. Versus the Catholics are a little bit more receptive to the conversation. They understand that end of life is there, and since their belief is that there's a heaven and all that, they're more comfortable with it. That's been my
So end of life care is something very important, Sylvia. Yes, I wouldn't say, Tia says that as Catholics, end of life is the beginning, and I'm not a particularly religious person. I am spiritual, but not religious. But no, Jewish people do not believe in cremation. Right?
You have to be trained before you can touch the body after death. Like only certain people are allowed. If you're not trained and like checked off as in the Jewish faith, you're not allowed to be with the body. Otherwise it's something having to do with you prevent them leaving or something. I don't know. I'm not Jewish, but I know that you got to be careful who's around the body after they pass.
Mm-hmm. And remember, sometimes depending on the Jewish sect, sometimes they will not let men and women together. So that's just something to think about. If you're coming from a Christian background, then that's something different than the way your organization may be, but respectful to their decisions. They have their beliefs and other people have their beliefs. Any beliefs that you know of, Jacqueline, I'm going to pull on you do you know any of the Mormon traditions that might be unique to them?
It just kind of depends. With the Mormon tradition, some of the members go through a religious ceremony in the temple and they wear special garments. And so if they've done that, they have to be dressed by somebody who has also gone through that same ceremony of the same sex, and be dressed for their burial.
Okay. All right. And so some things also, I used to work in a Catholic hospital, and there was one elevator that would just keep running from Friday night to Saturday night because there was a large Jewish community and they don't believe in electronics from Friday night to Saturday night. So they wouldn't push the button. So what would happen is this elevator would run the floor and it would stop on every floor and go down on every floor. And that was a way so that we could provide medical care to them, and be respectful to their traditions. Okay. So things to think about, different traditions that we don't know about, things that we're not familiar with. Any other cultures that anybody they know some traditions that they might share that we could learn from? Like Indian culture, I know it's Diwali, right? Diwali now? It's a festival of lights right now.
Yesterday.
It's 5 days though, right?
Depends on where it is. India, I think it's like 5 days or 7 days.
But in the US, it's only one.
Yeah.
Oh, okay. So see how some traditions change depending on where you live, those kind of things. So really important to keep these in mind when we're looking at a parish nurse. You don't have to be part of the community. You're just using their spirituality as something that's important. All right, we're going to do a quick case study on parish nursing. Anything else on parish nursing you guys want to know? Really, you're a community nurse, so you're doing everything you would do in any other setting. You're just being particularly sensitive to spirituality. Okay, and be real careful with our biases. We have to be aware of what we think, and what we think is fine for us, but we respect our patients, right? Now let's do a quick case study because these sometimes are a little hard. So let's take a look at one that I have for you. Now remember, even though that video showed them being part of the community, there have been several that are not. So don't think that you have to believe or have to follow the traditions that they have. Okay, so let's look at this case study. And what I'm going to do is I'm going to have you guys answer the questions. I want you to answer them in the chat, please. All right, will somebody read for me the case study? Don't worry about the name.
I can read.
Thanks, go ahead.
Harminder Sandhu is a community health nurse conducting home visits in a congregational community of older patients living in the Sisters of Mercy Catholic Independent Living Center. In addition to conducting visits to homebound clients with skilled needs, Ms. Sandhu also provides the residents with blood pressure screenings, diabetes screenings, medication counseling, and educational forums on a monthly basis. Although Harminder is of the Hindu religion, she remains sensitive to the Catholic traditions of the individuals she serves. As Harminder is leaving a visit with an older gentleman, she is seen leaving the apartment by his neighbor. She is approached by the neighbor and asked how his pain is being managed related to his cancer therapy. What is the most appropriate response?
Good. So I want you guys to read the responses and put your answers in the chat there. All right, good. Most of us have D's in our answers, so I'm going to call on somebody who answered D. Yeah, sir, what was your thinking? Why'd you pick D? Yes, are you with us?
Professor, he's
I'm
having
thinking
issues with
about-
the audio.
Oh, you're thinking about it? You're right, but why was D the answer? You want me to call on somebody else? Where's my chat? Raina, why'd you pick D?
Because professor,
Yep, you're good. Go ahead. Yes, sir.
because the HIPAA, we have to maintain the confidentiality with the patients.
Okay, why wouldn't we provide her with minimal details?
I don't know.
Somebody help him out. Why would we not provide him with minimal details?
Because that's still breaking
we could be-
confidentiality.
Yeah,
And we
it's
could be
breaking-
telling them more than what they know.
Absolutely. And we're not going to tell the neighbor it's none of their business, right? Because they won't like that
That's
too
rude.
much.
Yeah.
And we're not going to refer him to the pastor because what does that have to do with anything, right? Very good. Here's our next question. Somebody want to read the question?
I can read.
Thank you.
Okay. Harminder Sandhu enjoys visiting the Sisters of Mercy facility and is interested in applying for a position as the official parish nurse when the current nurse is ready for retirement in 6 months. What does Harminder need to do to apply?
Good. So you're going to answer in the chat again. This is a hard one sometimes for people. Oops. All right, we're all over the place. Nicole, you picked D. Tell me what your thinking was.
Well, I think that with the medical surge experience that you need to have an experience with a little bit of everything to be able to treat the patient.
Okay, so a lot of people think you need a year of med surge experience, but what if you're dealing with pediatrics?
Mm.
Right? We know we're dealing with older people because it said it, but when you're reading this question, there's nowhere that we've heard that we need to do anything with a certain year, a certain degree. We know they don't have to convert. What do we need to be completely aware of as a practicing parish nurse?
Your
Your
faith.
your medical experience?
No, we got to figure out what we know, right?
The problem is it's kind of vague. It doesn't specify, do you have to have certain qualifications, at least in the question. I know you said it earlier that you don't technically need to be a nurse, but know enough, I guess, but.
Yeah, so you have to be a nurse to be a parish nurse, but you don't have to be Catholic and you don't have to have a master's degree, that's for sure. But what you have to be is you have to be very aware of your own faith before you go caring for anyone else, right? Because remember, Harminder is not Catholic, so she has to know what she believes. So when she's confronted with something different, she knows that that's their beliefs and she doesn't try to inflict their mature faith. Spirituality is the key for parish nursing. So you just have to be aware. You don't even have to have it, but you have to have evidence that you have some faith that you believe in or don't believe in, so that when you're confronted with something different, sometimes that will make it a little more understandable. Does that help?
That makes
This is a
sense.
tricky one. I know it is. Everybody wants the 1 year med surge. I don't know why, but it's because you guys are told that in nursing school. And I can tell you, I graduated nursing school and never did med surge my entire life.
It's just, we see the word experience. You know what I'm saying?
I know. And so don't be afraid of it because you don't need the experience. Sometimes you learn, and a lot of nursing is learning on the job. So, you know, you learn a lot of things. And med surge, you're probably not going to see in a community setting as much. Like you're not going to do wound changes. You're not going to do, you know, what else do they do? You know, you're not going to do any EKGs on them. You're not going to be reading them. You're not going to be doing ACLS usually on them. Those kind of things are going to be more med surgery, right? So that's a hard one though. Parish nurses fulfill a variety of roles in an autonomous manner. Which of the following is an example as a facilitator? So remember what facilitator means. They're going to be helping things to come along. All right, most of us are picking B. One of us picks C, and why that is because of the definition of facilitator. And so what a facilitator is going to do is work with the congregation to actually increase access or extend meals for those who are homebound. They demonstrate an educator by writing, and they help clients know what resources are available as the liaison, the person in the middle. And then we're going to have those leading support during pastoral care. So that was more of a definitional thing out of our book, which we didn't really cover. So I'm okay with your answers on that one. And any questions on parish nursing? No. Okay, the next chapter that we go into is home health and hospice care. So I had something we were going to do, but since we'll go over it quicker than do what I was going to have you guys do. Okay, so home health and hospice care. Who's in home health care?
I am.
Heidi is. Anybody else? Lorelai is. All right, guys, what can you tell us about home health care? You probably know as much as the book.
Actually, what we do, we send out either if the patient is discharged from hospital or he has any disabilities or is referred from a clinic, we send help, either home health aid, which is HHAs, or we send the nurses physical therapy, occupational therapy, different services to help the homebound community, basically, or the people in need. And we do most of that we do either, IVs, we do wound cares, we do a lot of diabetic patients we have, and bedbound patients that need a lot of help, and physical therapy as well.
Good. What can you tell Lorelai?
Well, basically it's an extension from a patient when they come home from the hospital. It's to return them to their prior level of function. If it's a therapy case, and to promote independence. It's a short-term goal process. It's not meant to be a long-term service. Unfortunately, diabetics and patients with wounds who have multiple comorbidities, they're on service a lot longer, but it is also supposed to be a more cost-effective method than going outpatient or to the hospital every other day because their wound's infected or it's not healing or they don't have the proper medication.
Good. She brought up a good point, finances. There's a piece of home health care that insurance companies like, and that's because they're paying less than what they would pay if you were in an acute care setting, right? So they want you home. What else do you see when you're in the home? We talked a little bit about this when we talked about family. What kind of things do you guys see in the home?
You see a lot of the patient's family dynamic, their support system, if they have one, and how unfortunate for the elderly, how they kind of just get by as there isn't a lot of resources out there, or they're not knowledgeable on the few resources that they probably qualify for.
Good. And with that, we look at Medicaid and Medicare, and I don't know if you guys have experienced this in your practice, but oftentimes we know that Medicaid, Medicare will only cover nursing skilled options at home. So you're not going to have like a nurse's aide come in, because unless you can pay for that. What do we know about nurses' aides and home care nursing? It's extremely expensive. Now, that doesn't mean that the nurses get paid well. It just means that the patients get charged a ton. Okay, so think about that when you're looking at home health care. We know that when we're in somebody's home, what are some of the safety things we're going to do as the nurse?
Look around the house for like stairs, rugs, things that might, make the patient trip or get hurt.
Yep. What else? What other things are we going to check in the house?
Maybe their bathroom, like shower, the rails, I forgot what they're called, like the toilet commodes.
Yep. Yeah. What else? What else is important for our older people?
Family members.
I'm sorry, Raina, you said family members?
If they live alone or with somebody.
Okay. And what do we know about the older population? What are they very susceptible to?
Abuse.
Very good. That's our primary with them. And when we're in somebody's home, we really get a comfort. When we're a nurse, are we gonna go wearing our best clothes?
No.
No, because you have no idea what you're walking into. So you want to wear scrubs that you can throw in the washer and dryer. It's good, Tia. You're going to sit between the exit and the patient. No jewelry, no money. Don't bring your nicest watch or whatever. You don't know what you're going into. We also worry about weapons in the home too as nurses. We don't know who carries what, where, when, whatever, right? So things to think about with home health. It's an area that is always a need. Insurance companies will pay for those skilled nursing care. So as nurses, it's a good field to go in. There's some home health where you will do and follow chronic illness, like following asbestos patients. You'll go assess the home. You're really like a care coordinator. Make sure they're getting the care they're getting. Make sure that you can make the appointments for them, that kind of stuff with home health, okay? With your PowerPoint that we had with this chapter, and home health for me is one of those, I haven't done it, and I will be honest with you guys, I wouldn't do it because I don't have it in me. I don't have the ability to go into an unpredictable situation like someone's home. That to me is very scary. So I admire those that do that. That's just not something that I have chosen to do in my practice. Although I've encountered plenty of things in the hospital and plenty of things in the school that are unpredictable, but me walking into a house with bugs and rats just isn't my style. So, but we're gonna look at the PowerPoint real quick, just make sure I cover everything. We kind of covered home visits, so.
You're on mute.
Sorry, just 1 second. I'm saying goodbye to my daughter. She's going to swim, so just give me 1 second. Right, sorry about that. I don't see her when she gets home and then she goes to swim until 8 o'clock at night. So anyway, okay. So let's take a look real quickly at our PowerPoint on home health. And is that an area anybody wants to go into?
No.
No, that's a hard no, huh? Yeah, it takes a very special person, I think. There's a lot out there though. And you know what's interesting about home health? Either of you guys who are in home health, what's a real advantage to home health nursing?
Flexibility on your schedule.
Yep. You pretty much can, you're pretty much flexible on when you go. You might do your charting at home, might give you some flexibility. There's some advantages to it for sure. And you get to know the patient really well, and you get to know the family really well, and you can be the person who prevents infection, right? And you can help them that way. So there's some advantages for sure, but that's not something that I have had in my cards, but I admire those that do it. Okay, we're gonna take a look here. Oops, hold on. Sorry, guys. There's so many, I have so many PowerPoints open for you that I can't remember which one is which. So home health, we really want to worry about safety, which takes us into our next section, which is hospice. Who's done hospice? I know somebody has. Sylvia's done hospice. Anybody else do hospice? Lorelai, you've done it. Okay, that's an amazing field, an amazing field. What is something that you've learned from there?
The resilience of people when they're passing and how calm they can be. Those are very broad. Clinically, it's very broad. So you learn so much from that part. So like, it's, you know, as a nurse, you're going to learn, basically, you're going to do, it's more direct with the doctor and the diagnosis that you use and how the disease progresses. And then there's a spiritual part of it, and the comfort that you're giving families at that time is very rewarding. I truly do have a passion for it. So,
has anybody had any experience with a hospice nurse in their home or in someone else's home?
Yeah, I think the importance of hospice is actually because it lets you, it gives you closure without all the chaos, is I guess a way to say it. You avoid a lot of the, you know, police and what do we do now and who's going to call what and what, you know, the hospice nurse kind of takes care of all that. And once you're on the hospice program, you kind of put all your ducks in a row. It's not so much for the patient per se, it's more for the family and the ones that stay behind, you know, that it's a big load off of their shoulders and what to do next.
Good. I'm glad you brought that up, because that is something that I don't know everyone is aware of, but if you do not involve hospice at the end of life care, police can get involved. And that's the last thing somebody needs to be dealing with, right? So something I unfortunately had hospice in my home, and that was something that I learned that they came in and it was good they were there, because if they hadn't been, then it would have been pretty ugly. And the last thing that someone grieving needs to go through is a police officer questioning them. Legitimate, right? Everybody understands why it's done. It's legal, but from the perspective of a child of a family member, you know, that was not something. And you know, hospice nurses are just amazing people, in my opinion. I brings tears to my eyes, the thought of them. I mean, it just to encounter that every day and to be able to, you know, put your face on, put a smile on, give a hug, just an amazing field. So thank you for all of you guys who do it. And we're just going to take a look real quick. Sorry, I get very emotional. I lost my mom 5 years ago. And so just the thought of hospice brings tears to my eyes, so I apologize. But anyway, so we're gonna look at our home health and hospice together. It's really a sensitive topic for me, and I'm I'm your professor, so I shouldn't get sensitive over it. But like I've told you before, I'm human, so I sometimes have my weaknesses. So when we look at public health and hospice, we know there's specialties. Family caregiving is going to be our biggest thing when we're doing home health and hospice. Remember, family is whoever the people decide is family, right? So if they think that their neighbor is family, then their neighbor's family. We see who can assist them in providing basic needs and, providing direct care. We know there was a big evolution. Let me make this bigger because I can't, it's so small. We know that, we know that it's come far over the years. It's really come tremendously, very far. And that's a good thing. We've learned a lot through time. And so what we look at is early 1900s, MetLife included home care as a benefit. Why do you think they did that, MetLife Insurance Company? Why would an insurance company want home care?
Wasn't it to prevent fraud in regards to life insurance policies?
Yep. And then they could see what was really going on. Yep. And also it's a financial, they're an insurance company. Why do you think they wanted home health? It's way cheaper than acute, right? So people who work in people's homes, they're, seeing all different communities. Home health care is a specialty area. I'm trying to get through this, guys, so we get out of here. Hospice, know that we have had this since in the 1970s. We had Florence Wald who introduced this to us. In 80 and 81, we saw Medicaid and Medicare reimbursed, which was helpful for hospice care, because it's something that, as our co-classmate said, you really need to be there and help the family prepare as best they can. So we've had a whole different thing. What we want to remember with hospice and palliative care, that they're similar, but they can be very different. So what I want you to know about hospice and palliative care, and I'm just going through, make sure I don't miss anything here, is that what is our goal at the end? Our goal is to give respect, dignity to the patient, to the family, to involve them in the care, to make them feel as much ease as we can. It's a really hard time for them. Sometimes it's not hard, sometimes it is hard, but but whatever, we respect their beliefs, we respect what they believe in, and we go and support for the family and the caregiving. So I did that so quickly, I apologize, but I gave you guys that PowerPoint. So if I want you to, do anything with that, just review those PowerPoints. And I know we did it quick, but I'm trying to be courteous of you guys. If you have an exam in 15 minutes, I give you more power to you.
Yes.
So good luck, best of luck to you guys on your exams. You can leave if you want to. If you want to stay on, you can, but best of luck. And I'll see you guys next week.
Thank you.
Thank you. Good night.
Thank
night.
you.
Good night.
Professor, I have a meeting with you.
Yeah, I know you do. I know you
Okay.
do.
Thank you, Professor Alani, for letting me attend.
Oh, you're
your
welcome. I
lecture. It was
hope you
very
enjoyed it.
informative.
Sure.
Thank you.
All right, take
Bye-bye.
care.